I am Dr. Michael Gunther. I would like to thank the Southern Medical Association for the privilege of speaking to this group. I've been asked to talk today about biopsy of pigmented lesions, but I think in vernacular, I'd like to call that melanoma for dummies. The cutaneous malignant melanoma is a disease for which we are seeing an expanding incidence. We're expecting over 100,000 new cases this year, according to the American College of Surgeons. It is a demographically blind disease. The incidence increases with age. The overall average age of diagnosis is at 65. However, it occurs in all age groups, and in particular from women 34 to 39. It is the most common cause of mortality. So that may well be related to tanning beds, and we'll hopefully see that change. But we're seeing over 100,000 new cases a year with approximately 7,000 deaths in every year, and that number is expanding, as does the incidence. The lifetime incidence for Caucasians is approximately 2.6%. So it is that is increased from 1%. So it is a disease on the increase, and we want to talk a little bit about some of the diagnostic techniques and things that we can offer for that. Melanoma is not a new disease. The disease has been identified as early as 5000 BC by Hippocrates, found in mummies in 400 BC. From Robert Louis Stevenson, the black spot was a literary device that was invented in the novel Treasure Island. And it was quite interesting. In that book, pirates were presented with a black spot to officially pronounce a verdict of guilt or judgment. So nobody wanted the black spot. And in Pirates of the Caribbean, if you remember, the Dead Man's Chest version, Captain Jack Sparrow is presented with a black spot by Davy Jones as a marker that the Kraken can track. In particular, this appears as a boil on his palm of his hand. So the black spot was a mark of death to pirates. And melanoma has always been a fearsome opponent of sailors because of the sun exposure that they receive. Another quote from Moby Dick: "Close, stand close to me, Starbuck. Let me look into a human eye. It's better than to gaze into sea or sky, better than to gaze upon God." The glassy white eye in this photograph here, in particular this patient's right eye, gives one pause because the other eye is jaundiced. Now, this is a yellow jaundice, and again, like Ahab's bilious temperament, some gnawing, deep evil within. This was actually an assignment for medical students back in the New England Journal of Medicine. And as the novel proceeded, black is the pupil of her one good eye, malignant it grew in the one plucked out. Akin to the whale that could not be dispatched by the coldest steel that dove deep later to return, so did this woman's melanoma hide and then return. It would be ironic if her jaundice were due to a single metastasis to the porta hepatis, but that's an unlikely happenstance, like the single coil of a harpoon line that caught old Ahab around his neck and carried him away. The right eye here is a prosthetic, and this is the old adage, beware the man or woman with one eye who has a liver mass. And in this case, the liver mass is an obstruction, and that's why the left eye is jaundiced. So even in Moby Dick, we've got evidence of melanoma. So the fundamentals of cutaneous melanoma are the A, B, C, D, E's. And in simple form, A is for asymmetry, meaning that there's a difference from one side of a lesion to another. B is for irregular borders, not smooth and round, but irregular. C is for multiple colors or different colors, or the word variegated. D is for diameter, and E is for either growing or the eye test. And we'll explain what each one of these means. So asymmetry means that one half of a lesion does not match the other half. So that is the opposite of something that's smooth and symmetrical. Borders, uneven borders, those would be signs of a potential melanoma. Colors, a variety of them. We're going to show those in a moment. Diameter larger than a pencil eraser, and we'll do some comparisons with that. Things underneath that can be malignant, but they don't have to be. And then finally, the change in shape, color, growing out of the skin, bleeding, symptomatic, sort of the word evolution. All of those would be the simple A, B, C, D, E's, and almost anyone can remember those and keep those at a fingertips site. Now, as far as asymmetry goes, this lesion is fairly symmetrical other than the left side of it here, which has been outlined, as is this one here. These are the areas to biopsy. We don't necessarily want to biopsy the homogeneous portion of it. We want the asymmetrical portion. This one also fits the diameter and the borders notification as well. Borders. We're looking for things with irregular borders, like a map of Michigan. When we see something irregular like this, that is a worrisome lesion with a border that is not smooth or round. So irregularity on an edge that has a perimeter that looks like that, that would definitely be something to biopsy. Colors. Now, melanomas can actually be amelanotic. This first lesion here is apigmented. You can see it has the same irregular border. It's big enough, the diameter is, it's got asymmetry in it, but it also is pink and it doesn't have any pigment. This is an amelanotic melanoma. That should be biopsied. Melanomas can be black, the proverbial black spot. We can have brown melanomas, which again, this one's got some change in it. It's not just some smooth brown lesion. We can have purple lesions, red lesions, and even blue lesions, although these may be confused with a blue nevis. The point is, they have colors. Some of them may strike your eye. Some of them may not be quite as apparent, but just saying that they're black would miss a fair percentage of them. In general, when I have patients who ask me to look at something and they show me a spot or a freckle that's the size of the dot that a pencil lead might make, we're in pretty good shape there. So in general, a pencil eraser is 5 millimeters. Anything greater than that, again, is something that increases our clinical suspicion, and we would like to consider biopsy of that lesion. Now, the eye test. This is one of the simplest ones. I think most people that are in this audience would see this lesion and would say, well, that's clearly abnormal. But the classic scenario when people come to the office is they'll tell me, well, it just grew out of the skin. It had been there for a long time, and all of a sudden it grew out of the skin. Or, I just don't like that. That is enough of a reason to biopsy something. Symptomatic lesions that itch or bleed or ulcerate or scab and then scab over again. A long-time stable lesion that suddenly changes, a color change. Now, this is a classic one for me, is they say, my wife wants it off. A spouse or a husband will see something on their back or the back of their backside or their leg. It's not something they can even see, and they'll just say, my spouse has been telling me for the last 6 months to get that thing off. That is a good enough reason to get rid of it. And there's a lot of the time they'll tell me it's been there a long time, and then it has suddenly changed. So the eye test, when there's the ugly duckling mole, where someone has otherwise beautiful, pristine skin, and there's one mole that stands out, that's the eye test. Evolution means that it's growing or changing or coming out of the skin. Those are reasons to change gears and look for a biopsy. You don't need to make the diagnosis. What you need to do is provide tissue for a pathologist, and this you should have an extremely low index of suspicion. If you're not sure what it is, biopsy it. There's nothing wrong with biopsying a lesion. You'll never miss a cancer if you do that. The issue that I always encourage people is, and we're going to talk about techniques in a moment, but you don't have to be perfect with this. What you have to do, if you're not sure about what something is, go ahead and biopsy it. You'll never be faulted for that. The issue where there becomes concern is when it happens so many times, people are told that's nothing, and then it turns out to be something. Or it's taken off and thrown in the trash, and then a mole regrows, and they say, oh, that's just a keloid. It's a black keloid. No, it's not. It's melanoma. So for my family medicine physicians and our primary care doctors and nurse practitioners, you don't need to tell me that this is a melanoma. What I want you to do is say, this lesion looks concerning to me, or it was concerning to a patient or their spouse. I'm going to send some tissue to a pathologist to make sure it's not a malignancy. You'll never miss a cancer if you have a low threshold of suspicion. Now, there's another scenario that I see all the time, and it's called dysplastic nevis syndrome or familial malignant melanoma syndrome. These are people that have, it looks like a shotgun loaded with moles that are then splattered over what is typically their back or their trunk, not so much their arms and legs. This is an autosomal dominant condition. So when I see someone who has a melanoma and this, we do the genetic counseling. What we're looking for is a CDKN2A gene mutation. Now, dysplastic nevis syndrome, and again, there's a number of lesions on this gentleman's back that catch our eye, is generally the definition of 50 to 100 nevi. They have a 50 to 90% chance of developing a melanoma. So this is a special scenario where we like our dermatology colleagues to get involved, but oftentimes we will have a war of attrition on these people's skin over time, where they'll take 5 or 6 or 8 moles off at a time in the office or a little surgery center and try to reduce our risk by getting rid of what are atypical moles that are have a significant dysplastic component and are on the pathway to malignancy. So you'll see dysplastic nevis syndrome, and people always say, oh yeah, we're a mole family. Well, that's true, you are a mole family, and we want to make sure that you're not a malignant mole family. So dysplastic nevis syndrome is common, and you will see it, and if you keep your eyes open, you'll help identify kindreds who may have that. Now, there are a number of biopsy techniques. I'm going to illustrate a number of them. But the point is, it really doesn't matter which one you do. Whichever one you're comfortable with, whether you hit a sand wedge or a tee shot, it doesn't matter as long as it goes straight. I don't care how these are done. What I do want is for people to feel comfortable doing biopsies. Now, the simplest one is a punch biopsy. A punch biopsy essentially takes a round instrument with a hollow bore at the end. Once the skin is numbed up, this is advanced into the skin and twisted. It punctures the dermis and epidermis, then it leaves a little plug, which you just cut off with the scissors. These literally take about 15 seconds to do. They stop very quickly. You'd put a Band-Aid on them or you put a little silver nitrate on, and then literally they granulate over. These go from 2 to 5 millimeters in size. We'd prefer a 3 or 4 or 5 millimeter punch, but in this case, biopsy the most suspicious portion of the lesion. These are the CPT codes, the RVUs that come with them. Punch biopsies literally take no time at all. The only thing that hurts is actually numbing it up, and that is very minimal. So I'm a big fan of punch biopsies. Shave biopsies. Shave biopsies are scorned by surgical oncologists, but really I have no problem with them. The lesion is injected, it's lifted in the air, and then it's cut off. They leave an eschar, which is fine by me. The news is they do get diagnostic material. That is the important component of a shave biopsy, is that we get diagnostic material. There is an eschar, there may be a residual tumor in the base, but I at least have diagnostic material. And these are fairly easy to do, and a lot of primary care physicians do them. They don't pay as well as a punch biopsy, and they're a little more unwieldy, so that's why I like punch biopsies. They don't necessarily remove an entire lesion, but they are acceptable. I'm not a snoot about what kind of biopsy you perform. A narrow excision is a fantastic way to get a diagnosis. And taking a mole off, if it's an unsightly one anyway, no one's going to complain about that. If you feel comfortable doing those in your office, go right ahead and do those. The nice thing is if it's benign, you're done. If it's a diagnostic melanoma, well, then you have not burned any bridges as far as sentinel node biopsy. It doesn't mean they still don't need more skin excised, but there is complete tissue available for diagnosis. And if it's an atypical lesion, you'll have done the right thing. So again, narrow excision, nothing wrong with that whatsoever. The common attributes to all of these diagnostic techniques, there is histology that is obtained. There's a very minimal time requirement. They're all cosmetically acceptable. None of them leave large scars. They get sent to the lab and we get a diagnosis in a short period of time. And most importantly, the type of biopsies we just talked about do not compromise wide excisions or sentinel node dissections. What I don't like to find are rotation flaps, large excisions, skin grafts, things like that. That is not necessary for a diagnosis. That's more of a therapeutic entity than it is a diagnosis. Now, in the era of genomics for medicine, we have multiple genomic tests for breast cancer, and now we have one for melanoma. And I wanted to point out, once a melanoma has been diagnosed, these are Kaplan-Meier curves applying one of the new gene expression tests to that. And basically, this is a highly statistically significant ability for this genomic test to predict outcome. So once a diagnosis has been made, there is a highly reliable test with several zeros after the decimal point in the ability to identify risks of recurrence. Interestingly enough, most of these recurrences for bad lesions are within a year and a half. And if they have a lymph node involved, it's only 1 year. And in fact, if you look at the tails on these are 10-year follow-ups. The Kaplan-Meier curves here, really there isn't a lot of drop-off in fatalities after the 4th year. So a melanoma that's freshly diagnosed that is a high-risk lesion, a so-called class 2 patient, their risk of recurrence is in the first 4 years. It is not longer than that. So this gives us a window where we can very carefully examine patients and watch them for recurrence. That's how diagnosis leads to therapeutic salvation. Now, for thin lesions, which is what 90% of melanomas are thin lesions, and thin is a good thing, but thin is not always a good thing. So shallow is not an absolute synonym for innocuous. If we again look at the class 1A, 1B, and 2As, they do very well. But of a group of 300 patients here, about 5% of them, even under a millimeter, were class 2B lesions, the worst of the worst. And look at the difference in outcome here at 10 years. If you like multivariate analysis, the Breslow depth doesn't matter, the mitotic rate didn't matter, ulceration didn't matter. A lymph node involved mattered, but not very much. But with a hazard ratio here of 9.3, a bad gene expression product, even on a thin lesion, conferred a substantial risk of recurrence. In this case, 35% recurrence in 5 years. So shallow can be good, but it doesn't have to be. And that's the whole purpose here. Find these lesions when they're shallow so that we have an ability to get them before they have positive nodes or to identify risk before it becomes metastatic. Now, an example of some lesions. This gentleman came in with this on his chest, and every person that's watched this study could see that this portion is growing rapidly. We've got, it almost looks like a New England Patriots emblem here. We've got multiple colors, irregular areas. We've got a more pale area, and we've got a rapidly growing ulcerated lesion here. This is his chin, so you can get an idea. This is the largest single melanoma that I have ever seen. This is in the middle of his chest. So it was quite impressive. It had every hallmark of melanoma that you could imagine. It obviously didn't take much to get a diagnosis from this. If you flip him over, he had this on the back of his scalp. This looks like a blueberry stuck to a stain on his scalp. That's a hideous nodular melanoma. So this is again, an example of irregular borders, some amelanotic component to it, some different colors to it. Every one of these criteria would be one for a biopsy. This is a woman that came in who had a melanoma on her shoulder. She had a positive sentinel node in her supraclavicular and in her axillary basins, and decided to come back to see us in the office with all this visceral disease. Ironically enough, melanoma does this. She has all this cutaneous disease. She has no visceral disease whatsoever. Her liver and lungs were clean. She has responded very well to immunotherapy, but this is what we don't want to see. This is the sequelae of untreated or a bad risk melanoma. This is a melanoma on the head and neck, which are particular challenges. This ulcerated lesion right here was diagnosed with a shave biopsy. And you can see, if you look carefully, it's already growing back. That is ominous. So this was a skin graft after this was removed. His lymphoscintigram, which is a way to look for lymph nodes in the neck, demonstrated this basin, these three particular areas were to be looked for lymph nodes. So we took this piece of skin off, turned it into a skin graft, and then found lymph nodes down along his jugular chain underneath there. It's a different person with a head and neck melanoma. It had been done with a diagnosed with a narrow excision on the face. Now this is the planned excision area. This is also a lymphoscintigram. A lymphoscintigram injects radioisotope into the primary site and is hoping to turn the first lymph node in that basin radioactive. This is a drawing from the nuclear medicine department, and they identified a lymph node in the neck, which appeared to be the sentinel node. Well, in the operating room, we have a handheld gamma camera, and it looks like a cigar, but this is where the sentinel node is. Had I removed this and left this intact, I ran a good chance of this node being positive and this node being negative. Sometimes even removing this skin helps us to find this because the dose of radiation has been removed and it allows us to find the lymph node, which is less radioactive. These are experiential things that your surgeon hopefully has encountered, but this is some of the detail after a narrow excision that a patient is still subject to depending on the depth of their primary. A couple of other quick points. This is vitiligo in a melanoma patient, and this is autoimmune vitiligo. So you can see that this person has pigment which has been disappearing from their skin. That is a reaction to an autoimmune response against melanocytes, which is what we're trying to get. This is actually an excellent prognostic feature when we see patients with melanoma. So if you see someone who either had a melanoma and does this, or had a melanoma and did this while they were on immunotherapy, that is a good sign. They have a better prognosis because their body has mounted an attack against pigmented cells called melanocytes. So we love to see vitiligo. I know sometimes patients don't like the cosmetics of it, but the oncologic value of it is terrific. So what I wanted to summarize, and this is very straightforward, this isn't a computer program or some complex algorithm. If you have appropriate suspicion for a lesion and you employ the ABCDEs, asymmetric from one side to another, irregular borders, colors different than the typical pale brown, the diameter bigger than 5 millimeters, and then the eye test, or the spouse who says, I don't like this, I just don't like the look of it, get rid of it, that is enough for me. I see people at swim meets, I see people at cross country, I see moles all the time that I don't like the look of, and it's the eye test that counts. However the lesion is biopsied, it doesn't matter. I don't care how it's done as long as it's done. Always send the tissue to the lab. As a surgical fellow, we had people that would come in with trash bags full of medical records, and they almost always started off with a mole that was taken off. It was thrown in the trash because they said it was nothing. My spouse has asked me to take moles off, and I said I won't do it unless I send them to the lab. Always send it to the lab. And a final sort of take-home message, there's no such thing as a good mole. If you can't prove that something is benign, biopsy it, get rid of it. Your patients will be happy. You'll occasionally find a lesion that you didn't anticipate, and that will make for a higher survival and a very grateful patient. So with those things sort of in summary, I'm very grateful to have the chance to speak to the Southern Medical Association, and I hope that this will be productive for patients' lives as well as doctors, and I'll encourage them to be aggressive in biopsy techniques. Thank you.